It's happened. Thanks, everyone. Yes, so hello, good morning, everybody. Thanks very much for joining this SPCR Masterclass on health economics and policy making. So my name's Clarke. I'm a Principal Research Fellow in Health Economics at UCL, based in London. I work on a number of different clinical trials across different disease areas. I do a lot of work on different cancers and mental health, primary care, obviously quite a lot of primary care, plus various other things, sinus surgery and cochlear implants and various different bits and bobs. So we've got an hour and a half this morning, so we'll wrap up by 12:30. Please do ask questions as we go along if you would like to. There's quite a lot to get through. We'll see how it goes. There's a couple of slides where I'll ask you to do something in Mentimeter. So you can just zap a QR code with your phone for that, just in a couple of places. And yep, let's get started. So yes, do put questions in the chat if you would like to, or save them to the end, or put your hand up. And I think you can unmute and shout as well if you would like. So here's an outline of the talk. We're going to talk about what is economic evaluation in healthcare and why do we do it. We'll have a little exercise for you to just do by yourselves and send me some ideas through Mentimeter. Then we'll talk about a key concept, which is opportunity cost, and some key ingredients in health economics, health economic evaluation, which are pathway costs and consequences. So we'll talk about quality of life and quality adjusted life years, or QALYs. We'll talk a bit about the results of analysis and what it looks like, what it means. We'll talk about how we show these results to decision makers. So everybody likes pictures, so we use pictures. We use some nice graphs called the cost effectiveness plane and the cost effectiveness acceptability curve. And we also look at cost effectiveness thresholds. I'll end then with a couple of case studies where some policy-making decisions have happened, and I'll show you how the health economics has fed into those. Then we'll talk about some limitations and conclusions finally, and then there's a list of references and further reading. Oh, I'll go forwards. There we go. So economics, all economics, not just health economics, all economics is about choice, trying to make choices, trying to make decisions. What's the best thing to do? The way that I tend to think about this is you have two goods, you have good A and good B, and you're trying to work out how much of your budget to spend on each thing. So an example is, what am I going to have for lunch today? So I can choose lunch A or lunch B. I can have some sliced bread make peanut butter toast, or I can get some pita and hummus. And those are my two options that I've thought about for lunch, and I have a fixed £5 budget that I'm going to spend. So I can easily make this decision. This is very straightforward. I know how much things cost. I know what I like. I know what I had yesterday. I know what I've got in the fridge to put on these things. I know what's in the different things. I know the ingredients list. So I know everything that I need to know about making this decision. It's transparent and straightforward. So that's fine. In healthcare, things are less straightforward. So to sort of take this analogy forward a bit, if we can think about a perfectly competitive market, so this is a sort of economic definition of a type of market. So in a perfectly competitive market, it's easy for consumers to make choices about what they want, and it's easy for companies to sell things to consumers, because it's easy for them to enter the market and start selling things. There's nothing complex, everything's fairly straightforward, there's no barriers. In this situation, if the bread is too expensive, the consumers won't buy it. So then the companies, the suppliers, have to drop their prices in order to get people to buy the bread. So this is kind of a very basic idea of the interaction of supply and demand. If demand drops because the price is too high, then the suppliers have to change something. They have to change the price. The price has to come down. And this means that you can decide on the price of your loaf of bread in a fairly straightforward way by this interaction of supply and demand, where there's lots of different companies selling bread, lots of different people buying bread, and everything sort of evens out in a straightforward way. So we know what the prices should be because they're dictated by what people are willing to pay, and that's fine. We get efficient allocation of resources and clear prices. But in healthcare, this doesn't work for many reasons. So it's not a perfect market. It's not perfectly competitive because it's quite difficult to enter the market. You need lots of training and doctors and lots of research labs and lots of expertise, lots of upfront costs. It's quite difficult to just enter the healthcare market with sort of meaningful therapies. There's lots of asymmetry of information. So the patients don't necessarily know what they need. They don't know what's wrong with them. They don't know what diagnosis is. They don't know what the treatment should be. Sometimes neither do the doctors. So in primary care, you go to your GP, say, I've got these symptoms. The GP says, oh dear, let's do some tests. And so you do some tests and try and work what's wrong with the patient. Once they've worked out what's wrong with the patient, maybe the treatment is prescribed, and then not everybody reacts to treatments in the same way. So there's another level of uncertainty there in terms of how the patient responds to treatment and so forth. So there's lots of messy bits which make it less straightforward for health. Another complication is that we're not demanding and supplying the same thing. So in terms of the healthcare market, you supply healthcare, so drugs or interventions or hospital appointments or whatever it is you're supplying. That's not really ultimately what people want. They want good health, but you can't buy a loaf of health. You can use healthcare, you can buy healthcare, but that's not really what's demanded. So for all of these slightly messy reasons, there has to be some level of intervention in the healthcare market. It can't be left to itself. It can't, because it won't end up delivering what people need. And there are lots and lots of examples of government intervention in healthcare markets. So the existence of the NHS or other national health services is a big one. There's something called orphan drug status. So if there's diseases that, if there are rare diseases that have very few patients, then there's not really much motivation for people to come up with treatments for them because there's not a big customer base to sell the treatment to. So in order to get treatments for these rare diseases, the companies have to be encouraged by sort of tax breaks or other sort of financial motivations to try and produce these treatments that people need. So that's sort of a roundup of the complications of the healthcare market. So what we don't have, what we cannot get for healthcare is how much things should cost. It's just not there, it's not available. So what we do instead is we use economic evaluation to try and generate this information on what should the price be. Right. There we go. So ingredients for health economic evaluation. So you need a health economist, you need some information on costs, which is usually healthcare resource use, can be cost to patients, cost to the health service, cost to other things. You need some information on outcomes. So this is usually patient outcomes. So it can be quality of life, it can be number of heart attacks, or this sort of thing, different clinical outcomes. Oh, my cake is on top of the words. It just says various under there. If it's quality of life, then we capture generic quality of life at various time points, and we use this information to generate QALYs. We also need information on different covariates, so patient demographics, age, sex, and so forth, baseline disease status, and we would control for these kind of covariates, the same as we would for the main statistical analysis. We also control for baseline values, again, in a sort of standard way. So where's all this information going to come from? So quite often we get it from clinical trials. So here's an example of a clinical trial timeline, just very standard generic kind of looking trial. We're doing a trial on a thing in some people to see if it works. There's the funding, which might take a while. So conception, you're doing the funding application and so forth. That takes as long as it takes. Then once we've got some money to do the trial, we will set it up. We'll do all the paperwork, finalise the protocol, do the case report forms, do the database, get all the approvals and so forth. Then setting up the sites, talking to sites, then we'll start recruiting patients. All going well, we'll recruit all our patients. We'll do a couple of follow-ups. Maybe we'll do a process evaluation as we go along, asking people what they think about it and how it's been implemented. Then at the end, we gather all this data together that we've collected and we do 2 analyses. We do the main statistical analysis and we do the health economic analysis. So these 2 analyses come from all the trial data. And then at the very, very end, there's the reporting and dissemination. So that's just, you know, sort of setting up basic clinical trial kind of timeline. And while we're on the topic, I'm going to briefly talk about what's the relationship between the statistical and the health economic analysis. I know we've got a few statisticians on the call today. So the stats looks at, does it work or not? And the health economics looks at, is it good value for money? So that's it really. So the stats needs information on outcomes, plus the covariates for controlling for things. And the health economics needs outcomes and pathway costs. So as people are being treated and they're moving on their treatment pathway, how much are they costing? So you can have different results for the 2 analyses. They don't always agree. And if they agree, obviously that's great. If they don't agree, you know, slightly complicated write-up, but that's just life. So you can have a clinically effective result from your trial where your outcomes are better with your new intervention, which is great. And if the extra cost is low enough, then it's also cost effective. Brilliant. So we've got a win on both factors. And we can also have the answer where the new thing is not clinically effective. So in the green corner at the bottom here, so maybe we've got the same or worse outcomes, which is not what we were looking for, but there we are. And maybe the extra cost of offering this new intervention is too high. So it can be not clinically effective and not cost effective. You can also have one of these other yellow boxes where maybe we've got the same or worse clinical outcomes, but the extra cost is low enough or negative. I mean, maybe it's cheaper to offer the new thing. And if it's the same outcomes, then there's no downside to offering the new thing, even if it's not better than what's currently out there. And you can also have, this happens quite a lot, a new thing which is giving you better outcomes, so it's clinically effective, but the extra cost is too high, so it's not cost effective. And there's various ways that we can try and deal with that by asking the manufacturer to make it cheaper. That's always an option. Yes, so there we are. So that's the relationship between stats and the health economics. So we're on to the Mentimeter scan now. So do scan this QR code and imagine that you are a regional healthcare commissioner with a budget of £50,000, which you can spend on new healthcare programmes. How will you spend the money and what extra information would help you make the decision? So do zap this QR code here. I'm going to move over to the Mentimeter so that we can see everybody's thoughts as they're coming in. And when I do that, you'll see on the Mentimeter that this little sort of question is an image in the Mentimeter. So you'll be able to see that still when you go to the Mentimeter. Right, so I'm going to come away from this and go to the Mentimeter. I need to share before I do that. There, so I hope you can see this. Let's see. Yes, your regional healthcare commissioner with a budget of 50 grand. How will you spend the money? So you've got 3 different programs here. Inpatient rehabilitation, you've got £5,000 per patient. It reduces the length of stay by 4 days. Then you've got early intervention in something, £2,000 per patient, or you get a 10% reduced risk of admission. And the last one is individualised therapy for something, costing £1,000 per patient with a 20% improvement in quality of life. So have a little think about this while I drink some water and tell me what your thoughts are. Can everybody get into the Mentimeter? Yes, you would. You would need a common measure to compare across the 3 interventions. Yes, ideally. Oh, someone's gone for number 3. Jolly good. Impact of quality life on, yeah, so we need a bit more detail on the quality of life. How much the extra 4 days in hospital costs? Yeah, that's another one. How much is the typical length of stay per day? Yeah. How many patients are we thinking about? Yes. So we're in a very local situation here, aren't we? So cost effectiveness is one thing, but budget impact is another. How many actual people are we talking about? These are all very good responses. Good. Any more thoughts? Common measure, yeah. Oh, this is very good. What are the patient demographics? Yeah, so that's important as well, isn't it? So in terms of thinking about equity, you would want to know that we're affecting different groups equally, or at least we're not adding to existing inequality. Good. Oh, thanks, Katie, for putting that in the chat. Brilliant. Well done, everybody. Thank you. Good. So I can see you're all awake, which is excellent. Oh, cost per QALY, someone's just popped in there. Brilliant. Thank you. Good. So let's go back to the slides. Brilliant. Thanks, everybody. So you've all identified opportunity cost. So we have to think about what different options are. We want to know what's the impact across all 3 of them. We want to think about all 3 of them together and how they affect each other. So something we're going to talk about now is a key concept called opportunity cost. This is really the underpinning single most important concept for understanding why we do economic evaluation. And it's the idea that the benefit, it's defined as the benefit that would be derived from using a resource and its next best alternative use. So let's go back to the lunch example. My favourite lunch is peanut butter on toast, and my second favourite lunch is tuna hummus. So the opportunity cost of me choosing my favourite option is the benefit that I would derive from instead using getting my second favourite option. So the opportunity cost of me choosing toast is the benefit that I would have derived from having pita bread. So that's the definition of opportunity cost. And it's very important in terms of thinking about how to calculate the costs section of the economic evaluation. Right. Okay, let's carry on. So an economic evaluation in healthcare. So this is defining what economic evaluation is. So again, there's some really important sort of defining concepts here. So it's always comparative. Always, always, always. We're always comparing one thing to another thing or to some other things, but it's never a single arm. It's always a comparison. You've got our new thing and our old thing, our comparative thing. It could be 2 different drugs, 2 different styles of surgery. It could be a drug versus a surgery, talking therapies, diagnostic tools, service reconfiguration. It could be anything that you want to change, and it sends patients down a different pathway. It's not about choosing the cheapest option. There's also the consequences. So we need to look at the consequences of going down pathway A and the costs in terms of appointments and so forth of going down pathway A, and the same for going down pathway B. In the UK, it's been around for a long time. In other countries, also been around for quite a long time. The US actually was the original cost effectiveness sort of. It started there in the 70s and has fallen off slightly. But there are lots of countries where this is used explicitly in their approvals process. And of course, it is used quietly everywhere. Okay, so what do we include in pathway costs? I keep saying pathway costs. What are these? So it's things like costs to the NHS and personal social services. Oh, sorry, my acronym's fallen off there. PSS is personal social services. So this is what NICE tends to include. That's the National Institute for Health and Care Excellence, which decides whether something can be offered on the NHS or not. And it does that by looking at, does it work, and is it good value for money, and some other stuff that we'll talk about later. So costs of using drugs, receiving procedures, other interventions, visits, appointments, so GP, hospitals, and so forth. And we can gather this information during trials by asking people to fill in questionnaires, which is quite cheap and easy, but can be messy and can be a burden. So there are pros and cons to using questionnaires or getting information directly from records. So in a study where we recruit from a GP, we would, for example, get their GP records out of EMIS or System 1 or whatever they're using on a pen drive, and then use that as our data, like we did in the ANTLER trial. So if we're going beyond health service costs, we'd call them societal costs, which is a very unhelpful word because it means everything and nothing. So if somebody says it's been done from the societal perspective, then you have to ask them exactly what they mean, because they could mean anything. So it could mean including out-of-pocket costs to the patient and their family. So maybe they've had some private consultations, maybe they've had some travel costs or overnight stays for going into hospital or something. Maybe it's cost to the economy of people taking time off work, which again could be the patient or their family or their carer. Informal care is a really big one. It's starting to be included more in NICE analyses, which is great because it's really important. And other things. So cost of the judicial system, education system, if your health intervention might have knock-on impacts there. We also always include the intervention itself, so cost of giving the intervention itself, and we think about implementation costs. So this is not always done, but it is always important to think about. If you implement your new intervention, how does that work? How do you measure societal costs? Depends which bits. If you want to measure travel costs, you'd need to ask people to fill in a questionnaire and tell you how much they're spending on travel. Same for private healthcare, because there's no way to get it from records, really. Same for time off work. You would ask people, how many days have you had off work in the last 3 months? And yeah, judicial system and education system, there are some unit costs that you can get for those. But in terms of the actual impact on the system itself, they are quite difficult to get hold of because they don't have clear sort of databases that we can get into, like we do with healthcare. So yeah, it's quite tricky to measure societal costs. Thanks, Maria. So thinking a bit more about pathway costs, how do we decide what to include? So there's all sorts of options, but how do we know? Well, we have lots of conversations with people. So the health economist will ask people, you know, what happens to patients who have this disease and who get this intervention? Where do they go? Who do they see? Do they see different people in the hospital? Do they go back to the GP a lot? Do they see the nurse? Do they get district nurse visits? So we would sit down and have brainstorming with the clinicians, with research nurses and with patients and carers and families and so forth, because they all have different views on the patient journey. And we want to try and capture all of it and put it into a nice, simple questionnaire to fill in, supplemented by patient records. So this is quite a big part of the process, talking to people and working out what happens with the patient. Then, of course, we can't include everything because no one will stay in our trial. If you ask people too many questions, they will get bored and leave, or they'll get exhausted and leave. So there's a trade-off between asking too much and asking not enough. And it changes with every trial. Every trial is different. Every trial team is different. Every patient group is different. Every investigator is different. You know, they all have different views about what they want included and what we don't need to worry about. So yeah, lots of conversations. This is all based around who is the analysis for? Who is the decision maker who's going to look at our analysis and then make some change on the basis of it? Usually we think about NICE for that, so the English regulatory approval body, because that tends to be who we're aiming at. But we also think about local decision makers and other decision makers. But that's a big part of the question. Who do we need to be aiming this at, and what will they want to know? So once we've worked out resource use, so resource use is things like how many GP appointments, how many packets of antidepressant, that's a resource use. And then you get the unit cost, which is the, £1 per packet or £36 per GP appointment. And you multiply the number of things by the unit cost and you get the total cost. So that's it really. So it's quite simple. It's just getting the data and working out exactly which bits you want is tricky. But the actual mechanics of doing it isn't that difficult. So we get these unit costs from websites. So there's reference costs, NHS reference costs, that has all the stuff for hospital visits. And the schedule of costs was designed for sort of reimbursement costs. So they're not exactly reflective of how much things cost each actual individual hospital. It's sort of a national average. But that's fine if we want to have a sort of generalizable result. And then the PSSRU is Personal Social Services Research Unit, which collates all the costs for primary care and community care. So again, it's a huge document, and you sort of scroll through all the tables and work out which costs you want to use. So we talked a lot about costs. What about consequences? So we've mentioned quality of life and QALYs, and these really are the main sort of generic outcome measures that we would think about in health economic evaluation. But there are lots of different consequences that we can also think about. So the trial might have a primary statistical outcome, which is something clinical, because that's the main question. Does our new drug delay progression in Parkinson's by changing values on a questionnaire? Does the new drug avoid heart attacks? Does it reduce tumor size? Does this new radiotherapy reduce tumor size whilst leaving surrounding tissue alone? So there's all sorts of really important clinical outcome measures that we want to know as part of the trial. But we also need to look at the generic outcome measures, which you guys identified before, which is around trying to have a good outcome for the health economics. So we've got a comparison case here. So we're back on the Menti. It's the same Mentimeter. So I need to go back to the thingy and move it on the page. And we can, so it's the same, if you've still got your phones open, it will be the same Mentimeter. There it is. Right, and I can, oh, here we go. Yeah, so better screening test for breast cancer versus usual care. So what, if we're in this situation where we are trialing a new screening test, I've said it's better, which is obviously slightly meaningless. Maybe it's more specific or more sensitive, or some combination of the two, or less painful, or some other improvement on what we currently have. So what could be some differences in costs and consequences between trying this new screening test versus usual care? So do put in your thoughts, and we're thinking about the short term or the long term. Good. Oh, lovely. Yeah. Acceptability of patients. Cost of screening could be more expensive, yeah, and use more resources. Method of screening better terms of cost and discomfort of the patient, yes. Acceptability, yes. Early detection of breast cancer can mean less costly medical intervention, yes, absolutely. Early is always good. Better quality of life over the short and long term. Well, definitely over the long term. Oh, pardon me, long term. Patient satisfaction, accessibility, yep. Implementation costs, yep. Do we need to buy new machines, that sort of thing? Different training for people. Number of patients willing to participate, yes. So uptake's really important, yep. Good. These are some really good thoughts. Thank you, everybody. And I've got one more along the same lines. Oh, I haven't reached the end of the presentation. Oh no, I've skipped one. Oh, I've lost one. No, I've lost one. Ah, okay. I had another one which was about schizophrenia, which I seem to have lost somehow. Oh well. Never mind. Those are some very nice answers for the breast cancer example. Thank you. So let's go back to the slides. Oh, let's go back to the slides. Here we go. Good. So this was the schizophrenia one, which I've somehow managed to lose off the Mentimeter. So I'm going to assume that you will have told me some very sensible responses for that one as well. Some of the big ones for schizophrenia are side effects, because a lot of the current drugs have side effects. So those are the two kind of case studies where we're thinking about a comparison. This is a slightly trick question. What if we want to consider both 1 and 2? I'm sure you would tell me the responses very quickly. We need a generic measure to look at both of them. You can't do a direct comparison, and we don't really need or want to do a direct comparison. We just want to have a way of looking at these different disease areas using the same assessment criteria. So that's fine. So we've talked a bit already about limitations of clinical outcomes. So that they tend to be specific to a condition, which is fine if that's what you're looking for. But actually, we tend to want something generic so that we can compare across different areas of disease and healthcare. Thinking really about NICE and what they want to do, because they need to look at all types of healthcare. Clinical outcomes only capture one thing, really, so they don't capture all possible effects. And they also don't reflect preferences for health states. So we're going to talk a bit about preferences later on. So all of this means that even if the trial's primary outcome is likely to be a clinical measure, and this is the right thing, we do also need a different outcome for health economics. So we use QALYs. Here we are. So quality adjusted life years are a generic outcome measure. They incorporate both quantity of life and quality of life, and they are a two-dimensional measure, if you like. So they're calculated as the area under the curve. So I've got some slightly pointy curves here for you. So the blue one on the top right is 1 QALY. So this area is 1 times 1 equals 1. So we've got survival of 1 year in this perfect health state. So perfect health means that you have a quality of life score of 1. The red one down on the bottom right here is also 1 QALY, so we've got a half times 2. So this is still an area of 1 QALY, so where somebody has got a half perfect health state and they're in it for 2 years. And you can also have 1 QALY by adding up half a QALY each for 2 different people. So that's just a reminder of what QALYs look like and how they're calculated. So the y-axis on the previous slide was, I called it the quality of life score. It can be called quality of life score, utility score, utility weight. So there's different names and they all ultimately mean the same thing. So the people's quality of life measured on the scale of 1 being perfect health and 0 being equivalent to dead. And this is important, the 0 being equivalent to dead. So you can have negative values. It's a bit of a philosophical question, but it is possible to have a negative quality of life sort of valuation. So any health state that you can describe, you can come up with an experiment to attach a utility weight to it. And I'm going to show you how that works on the next slide. So these are just a couple of examples. So people in trials who'd filled in a questionnaire and their utility scores were about 0.8 for women who'd had breast cancer and then surgery and then recovered. And there was a group of adults who'd had mood or anxiety disorders, and they had a quality of life of only 0.5. So they're often measured in trials using the EQ5D, which is NICE's preferred quality of life measure. So this is the questionnaire, or this is the main bit of the questionnaire that you would ask people to fill in trials. This is the EQ5D 5 level. So the 5D means 5 domains, so mobility, self-care, usual activity, pain or discomfort, and anxiety, depression. And 5 levels means there's 5 levels of response for each one. So this health state with the red crosses marked here can be described according to just the vignettes of text that you've got here. So slight problems walking about, slight problems washing or dressing, and so forth. Slight problems, usual activities, moderate pain or discomfort, and moderately anxious or depressed, because these ones down here are ticked at box number 3. Then you put these 5 responses into an algorithm, and it spits out a number. And the number that you get if you use the algorithm by Nancy Devlin and colleagues is that the utility score for this health state, the 22233, would be 0.673. So then that sits here on the y-axis of those curves that we saw a couple of slides ago. This is the second page for the EQ5D, and it has to be used in order to be valid, in order for the questionnaire to be valid. But we don't actually do anything with this number. It's part of the process of filling in the questionnaire, but sometimes we report it, often we don't, because it tends to confuse people. It's not the same as the utility score that you get from the algorithm. So what's this algorithm? How does it work? So it's really important to distinguish between the valuation that tends to be done once, and then using the questionnaire in clinical trials that happens, hundreds of times, lots of times. So the valuation was done originally by Dolan et al. In 1997, so quite a long time ago. And this was for the original 3-level version. So we've got the same 5 domains here, but they've only got 3 levels each. And this was fine. This was what was used for a long time. But then people wanted to have less ceiling effect. So everybody kept saying they were fine, basically. Everybody said, I have no problems, no problems, no problems. So everybody kept answering 1 to everything, and there's this ceiling effect. And they thought they could try and get rid of that a bit by having 5 responses instead of 3 responses. And it's worked a bit. There is still a ceiling effect in the 5-level one, but it's less bad. Anyway, so the 3-level was the original one. And the way that the valuation study worked was there were, I think, 3,000 members of the public in the UK who were shown a bunch of these sort of health states. So the one that's marked here is 1, 1, 1, 1, 2. And people were shown 15 different health states and asked to value them. So there's a bit more to it than that, but that's the crux of it. They were asked to value each health state by considering, by trading off time. This is time trade-off. So they were trading off time. Ooh, I've got a question. Yes, the last page of the EQ5D is tricky. Yeah, fair enough. Yeah, it is very difficult to interpret. There's not been a huge amount of work done on that, except for people to say that, yes, it doesn't always tally. Yeah, not sure. Sometimes people, I mean, a visual analog scale is a useful tool in itself, and people do use it. Yeah, it's not straightforward. It's not straightforward, certainly. Yeah, thank you. Good. Okay, so the tab itself. So people are asked how many years in full health followed by immediate death would be equivalent for you to living in 10 years. The wording of this is quite clunky, isn't it? 10 years in this health state. So they have to choose between 10 years in this health state, which for this one isn't that bad. 1, 1, 1, 1, 2. Well, depends what moderately means. Yes, 10 years in this health state, or less than 10 years in full health. And so they have to try and everybody answers this differently, you know. Some people will say, no, 10 years, I'm fine, 10 years is fine. And some people say, oh, moderately anxious or depressed, oh, no. And they'll say, you know, 1 year. So you do get a range of responses, and they did get a range of responses. And they used the responses from these 3,000 people who'd been asked to value a number of different health states. They did a big regression analysis and worked out for all of the health states that you could get, they worked out what the sort of ratio was. So this was done for the 3-level and then published. And then every time the 3-level was used in a clinical trial in the UK, that tariff was applied. So that was where that came from. They did a very similar thing for the 5-level. And that was published as well. So why can't they go forward? There we go. They did a very similar thing with the 5-level, but NICE doesn't like that one. There's some criticism of the methods that they used in the 5-level. So the current preferred option for NICE is to use the 5-level, but then map back to the 3-level. So I think using the 5-level is kind of future-proofing it because it is a more sensitive measure, but then you're mapping back to the 3-level tariff. So it's a bit of a shame. What we tend to do is use the 5-level and then do the NICE mapping as the base case analysis, and then also produce the answer using the Devlin new 5-level tariff and have that as a sensitivity analysis. And there's always a slight difference, but it's not a huge difference. So that's part of the sort of complications around using EQ5D, but it doesn't make a big difference. So other limitations around EQ5D and QALYs are that utility scores from any questionnaire, I suppose, are not reliable for psychosis or other sort of episodic or very difficult and different diseases. And they're also not useful for people recovering from severe mental illness because those 5 domains don't capture anything else. They capture what's in those 5 domains. It doesn't account for spillover. So if you have a carer, then the EQ5D looks at you, but it doesn't look at your carer. So adding in other people into the analysis has to be done in a different way. It's very difficult to use quality of life measures in children because it's really hard to value it. So asking kids to imagine being in a certain health state for 10 years and then dying or dying sooner is, some people think it's unethical to make children think about death. Some people think it's just, you know, they're all quite bloodthirsty and mad, so maybe you wouldn't get a meaningful response. And, you know, when you're sort of 8 years old, it doesn't mean anything to think about that sort of question. So it's very hard to value it. So what they've done with kids' questionnaires so far is they've asked adults to value it, trying to imagine that they were 12 or, you know, this sort of thing. So it's been valued by adults, but the wording in the language is all with children. There are lots of different measures. The ones with kids are tricky. But to be honest, the ones with adults are difficult as well. It's quite a difficult sort of concept to get your head around. But having said all of that, it's the least worst option. So it's the method that we use at the moment, calculating QALYs from utilities from EQ5D using the preferred value set, is currently the best thing that we have. So there are many issues with almost all of it, but it works for now. There's lots of research around trying to improve things. Okay, so we've got a bit more about other aspects of health economics. So let's talk about different types of economic evaluation. So the original one was cost-benefit analysis. So this has been around for probably millennia, you know. So it's thinking about, if I want to build a new bread factory, so now I'm a bread manufacturer instead of someone who eats toast. So I'm a bread manufacturer, I want to build a new bread factory somewhere. So in city A or, well, country A or country B, location A, location B. So I will look at how much it costs to build a factory, hire the staff, transport, the product around, buy the ingredients. You know, there's everything that I would need to build my new factory. Well, I'll think about how much it costs. I'll compare location A to location B, whichever one is cheaper is what I'll go for. So I'm a company and I want to make a profit. So that's cost benefit analysis broadly. It's quite difficult to use it in health because not everything can be valued in monetary terms. If you want to improve your health by having fewer heart attacks or not having a broken leg, then how much would you be willing to pay for that? So people do ask that question, but it's incredibly difficult to answer because people have different salaries, different approaches to things. It's really, really hard to put a monetary value on something to do with health. So we basically don't do that. So cost effectiveness is the next type of analysis, and that just keeps the effects in natural units. So episodes avoided, heart attacks avoided, you know, whatever the clinical outcome is, we use that as a measure of effects. Then the next one down is QALYs, and this is because we are thinking about bodies like NICE who want to approve things across a range of different disease areas. They want something generic. So that's how QALYs came about. So it combines mortality and morbidity. It can be used in any disease area with, you know, more or less. So that's fine. And then the last two at the bottom there, so cost consequences is where you don't have a single outcome. You have a bunch of different outcomes. You're kind of interested in all of them. So you would just collect them all and list them all. So you don't have a single answer for the effects. You just have a shopping list of different measures. So this is really useful in early phase studies and in feasibility studies where, so in a feasibility study, your outcome is how feasible it is. Can you recruit? Can you retain? But also you might have a bunch of different other clinical measures or quality of lifestyle measures, and you would just capture them all and report them all. Cost minimization is another one. We don't tend to use it much because it requires a bold assumption of identical outcomes in each arm, which is just almost never true. It is used in devices where the assumption is that the device streamlines the pathway but doesn't necessarily change the outcome. I think it's slightly problematic, but that's where we are at the moment. But yes, so those are sort of main types of economic evaluation. You'll see in the literature people saying cost effectiveness, and I say cost effectiveness when I mean cost utility. They're kind of interchangeable. Cost utility definitely means QALYs. Cost effectiveness could be either. And all of these analyses, you can follow it up with a budget impact analysis where you're looking at how many patients are we actually talking about here. So that's what we mentioned earlier on in that decision maker exercise. So how do we present the results? We present them as the incremental cost effectiveness ratio. So we've run a trial, we've done all the paperwork, sorted out the database, recruited the patients, captured all the data, and now we're adding everything up at the end, and we're looking at, does our new treatment pathway cost more or less than the old one? And does our new treatment pathway result in better or worse outcomes than the old one? And then the end result is, what is the extra cost per outcome gained? So this is a cost effectiveness analysis. So we're looking at the extra cost per whatever, per relapse avoided, per case diagnosed, this sort of thing. So this is the kind of answer that you expect for a cost effectiveness analysis. A cost utility analysis is completely the same, except our outcomes are QALYs. So incremental cost per QALY gained is the result for our cost utility analysis. So when we're presenting this to decision makers, we use diagrams because they're useful, they're easy to interpret, they're easy to explain. And the main one we use is the cost effectiveness plane, which is this plane here. So it's all about differences. So difference in costs on the y-axis, and difference in QALYs on the x-axis. So if we are in the, let's start at the bottom. So bottom right-hand corner, let's say our new treatment costs less. So the pathway is cheaper than the old treatment. Maybe the drug's cheaper, maybe there are fewer side effects that require treatment. For whatever reason, the pathway costs are cheaper, which is great. And it gives us more QALYs. So this is really easy. There's no decision to make, you know, it's already done. The new treatment dominates the old because it's cheaper and better. So that's fine. If we're on the opposite side, so we're in the red corner, up at the top left, the old treatment in this scenario is more expensive in terms of the pathway costs and worse. So again, that's a really easy decision. We will keep, sorry, I think I said the wrong way around there. The new treatment is more expensive and worse. So the old treatment dominates and we keep the old treatment. So those are the easy options. So we're not usually there. We're usually in one of the others where, so top right here, the extra benefit, there's more benefit for the new treatment. So it gives us more QALYs and it costs more. But how much more does it cost and how many more QALYs do we get? And then the opposite side here, where the new thing is cheaper and worse, how much cheaper and how much worse? And again, this is a kind of a sort of social and political question of whether it's acceptable to have a health loss for cost savings. Because there is an opportunity cost. If you have cost savings, you can spend them elsewhere and have a net gain in health. But the people currently getting whatever the old treatment is might not be so keen to give it up. So a bit more about this then. How do we decide whether it's worth it? Is it good enough value for money? So this is the value for money bit. This is all about thresholds. We have a cost effectiveness threshold, which is this line, this straight line here. And the gradient of this line, so the slope of this line is the threshold. So if there's a steeper slope, it's a higher threshold. And the way it works is if you're below the line, you're below the threshold, it means you've got more enough QALYs. I'm sure that's not good grammar, to justify your extra costs. So the extra QALYs do justify the extra costs because there's lots of them and the extra costs aren't that high. But if you're above the threshold, the extra costs are too high to justify approving the new treatment. So I hope that's all very clear. In terms of doing the analysis, so every time you have an analysis, there's uncertainty. Every piece of data has uncertainty. Parameters are estimated, probably from trial data, maybe from other places. People who participate in trials are weird, so they tend to be younger, have higher socioeconomic status, fewer comorbidities, whiter, more male. So these are sort of problems that we have with trial participants, more compliant. Every assumption that we make introduces possible error. So have we used the right comparator? Are the data that we're using in our analysis representative of the population? Do we need to supplement the trial data in some way? How good is the information on effectiveness? Have we captured it properly? Was it the right measure? How have we dealt with missing data? What bias are we introducing in the way that we've dealt with missing data? Have we included all the costs? Have we chosen the right cost perspective? Is it NHS and personal social services? Or do we also need other things beyond that? And have we included all the relevant costs and outcomes for both arms? So all of these things carry some uncertainty into our analysis. And that's fine. There's always uncertainty in analyses. That's not a problem. It just means that we have to list them and test them and see what impact that they have on our results. So part of our job as the analyst is to test all of these uncertainties in different sensitivity analyses. So I'm just plugging in the speaker, the battery's going. So we need to show the decision maker how good the result is, what assumptions we've made, and what could be different if the assumptions were different. So we can look at parameter uncertainty. For the within trial analysis, we would do bootstrapping, which I'm not going to go into today. For a decision model, we would use joint probabilistic sensitivity analysis, which you'll see some results for this, but I'm not going to go into how it's done today. There's uncertainty in structure. So the structure of our analysis, especially if it's a decision model, then there's some uncertainty there because we could have done things differently. There's scenario analysis. So we can test different scenarios and see what that means. So this could be subgroup analysis, or it could be other scenarios. And there's also threshold analysis. So I'm going to talk to you a bit more later about threshold analysis in one of the case studies. So NICE's position, I've talked a lot about NICE. What do they think about things? They have thresholds. So the standard NICE threshold is £20,000 to £30,000 per QALY gained. So if you're ISA, if you're a company and you've submitted something to NICE and you want it to be approved, if your ISA is nice and low, i.e. the extra cost is quite low compared to the extra QALYs that you get, then it's fairly likely to be accepted. If it's a bit higher, so maybe it's over £20,000 per QALY, then NICE will look even more closely at the degree of uncertainty around your results. So if there's lots of uncertainty, that's not helpful. And they'd also look at other aspects that relate to benefits that are not captured within the analysis. So maybe there's some spillover effects that are not captured in QALYs. Maybe it's for severe mental illness, so the QALYs aren't really a great measure. And there could be non-health factors that are also important. And then the higher the ISA gets, the more important all of these factors become. And then there's a very high threshold of £100,000 per QALY. And this is the new threshold that's out at the moment for highly specialized technologies. So this is kind of trying to cover gene therapies and that sort of thing. So they would also consider other things around that. So the impact of technology on the delivery of the specialized service. So this is a lot about implementation, actually. And again, additional staffing and infrastructure requirements. So if you've built a proton beam machine, then you need all sorts of other infrastructure things to be built and put in place as part of that, and training and so forth. So all of these things that NICE makes decisions about doesn't necessarily exactly dictate what's offered, because there's also budget impact analysis. And the other thing to note here is that these values are empirical. So when NICE started back in the 90s, they didn't explicitly state that they had a threshold. They just started approving things or not. And then something like 15 years later, somebody, an academic, went back through all of the results, because everything that NICE has published has approved or not approved is online. So somebody went back through all the results and looked at all the technology appraisals and whether they were recommended or not recommended. And they discovered the threshold is about £20,000 to £30,000 per QALY. And for ages, NICE said, no, we don't have a threshold, we don't have a threshold. And then eventually they said, yes, all right, we do have a threshold now, it's this. So this is now their accepted threshold. But it wasn't specifically deliberately chosen, it seemed like the right thing. Which I think is also partly why it hasn't changed since the 90s. It's not gone up with inflation, it's stayed the same. And this is probably a good thing, because there was some work done about 10 years ago now by Clarke and co-authors, where they looked at the actual cost to the NHS of producing a QALY. So they were looking in primary care, and they looked at how much primary care health service do you have to give people in order to generate a QALY, so one quality adjusted life year. And they did this big analysis, and the answer was about £13,000. So what that means is every time something is approved where the ISA is above £13,000, there's a net loss of health, because you're displacing healthcare, which could be generating QALYs more cheaply. So obviously it's a bit more complex than that, but that's basically what that means. So yes, so the threshold not increasing is probably a good thing, in my view. So what else goes into nice decisions apart from cost per QALY? All sorts of things. So uncertainty we've already talked about. Equality and diversity legislation I've talked a bit about. So we don't want to increase inequality. So that's a big part of it. Innovation. So that we've already talked about as well. That's to do with the highly specialized technologies having a higher threshold, because they want to encourage innovation and new therapies, new treatments in new diseases and so forth. Additional health benefits. So this is stuff that's outside the QALY. So that also is part of the nice decision-making process. And social value judgments. So this is things like, should there be different thresholds for different disease areas, like orphan drugs or neonatal care and that sort of thing. So there's all sorts of other things beyond the simple ISA that go into nice decision-making. So we are onto the case studies. So this is the first one. I'm just going to pause actually. Does anybody have any questions? Why do we not use 13K as a threshold? That is a good question. I wondered that myself. I think for pragmatic and, well, people disagree with where it came from. People disagree about everything. But also, if we did suddenly start using 13K as a threshold, loads of drugs that we already have would suddenly get unapproved. It would be very difficult to change the threshold. I suppose they could sort of gradually try and nudge it downwards. But again, even that, I think, would be really hard. I think their best option is to not increase it and wait for inflation to catch up. I think it would be socially and politically very hard to actually decrease it. EQ5D. Yes, we do have a different, so sorry, yes. Going back to the EQ5D, using the UK index, do we need a different index for each different country? Yes. So the EQ5D has been translated into, I don't know, dozens, hundreds of languages, and probably about 20 or so, I don't know exactly how many, but quite a lot have their own tariff. Which makes sense because different countries, different cultures, different linguistic associations with the words, even if no translation is perfect. So there are different tariffs in different countries. Yeah. How do you compare it? Ooh, yes, that's a good one. So we've got a multinational trial running at the moment, and we are capturing data from who are we getting? France, Germany, Italy, Poland, Switzerland, a few other places. And we're just in discussions now about how exactly to do this, because you could apply one tariff, apply, the central trial is being run by Denmark. So we could apply the Danish tariff across everybody, or we could apply the local tariffs. Although the Swiss one, we'd have to use French or German because there's not a specific Swiss one. So I think what we'll end up doing is trying to decide which is the best as a base case and then doing the other method as a sensitivity analysis. Was that what you meant? Did you mean a different question? Yeah, okay, cool. Thank you. How generalizable? Yeah, so that's part of the issue. So the 13K was from primary care, and I'm sure it would be, well, would it be more expensive in secondary care? I don't know. Things are more expensive in secondary care, but if you get more QALYs for them, then maybe it's worth it. Don't know. I'm just trying to think if someone's also done it for secondary care. I'm not sure actually. I can't think off the top of my head. But yeah, potentially not super generalizable. But then everybody goes through primary care. So thank you. Other questions just before we go on? Oh yes. Oh, this is an eternal question. Yes, the aim of the EQ5D and QALY seems to be to make things more comparative. However, if remaining years of life is a key part of the measure, wouldn't that bias away from interventions that are aimed towards older people or decreases with lower survival rates? Yes, that is a problem. The way that I try and rationalize this is that the cost per QALY is calculated within a patient group. So if you're doing cost per QALY gained in an older population, you're comparing an older group of patients getting treatment A with an older group of patients getting treatment B, and that's the cost per QALY that you get. If you're doing it is a problem. It is a problem. There's a paper that was published a few years ago called when is a QALY, no, what is it? A QALY is a QALY is a QALY. And it's this argument about inherent bias in QALYs. There's all sorts of problems with it. So quality of life, so for example, if somebody has a disability that they were born with, or some condition like blindness or something that they were born with, they might consider that they always have perfect health when they're not ill. But if you ask someone who's not blind to value being blind, yes, quality of life is very subjective, then they might consider that they don't have perfect quality of life. Also, people who have chronic illnesses, or not chronic illnesses, but people who have sort of lifelong conditions get used to them to a certain extent. It's very subjective. Yeah. With the EQ5 to imagine outcomes, how does this account for biases? Not very well. I mean, what we do in longer term decision modelling is we apply a discount rate. So any decision model which is going out more than a 1 year time horizon has a discount rate. So because future QALYs and future costs are worth less than they are right now, because humans want things now. So costs are valued more highly now, or money is valued more highly now, and QALYs are valued more highly now. So there is a discount the rate that we apply for longer term decision models, but that doesn't cover it. You know, this is still a difficult area. Yeah, good. Yeah, you could go off on tangents into huge amounts of literature on all of these questions. These are really good questions. Brilliant. Thank you, everybody. Okay, so let's carry on. So this is a case study that we've just sort of pulled out of the NICE documentation, just to illustrate everything that goes onto the NICE website and show how it's used. So Palforzia plus avoiding peanuts compared to avoiding peanuts, and it's for treating peanut allergy. So the population in this comparison are people who have tried everything else. They've tried other medications and they've not worked. So Palforzia is kind of a last ditch attempt. The company wrote their submission. They sent it to NICE. They had a base case ISA £23,000 per QALY gained. NICE sent it to the evidence review group, which is a group of academics, the independent group, that goes through the analysis and checks all the numbers. And they came back and said, yes, fine, looks like it's about £20,000 per QALY gained. So that was it. So recommended for routine NHS use in children and young people aged 4 to 17. And all the documentation is there in the committee papers online. So just to show you, this, it's just, you can just put it off the website. Everything is there. Company base case 23,000. And there were various scenario analyses and so forth that they reported. And the ERG had a look at the different scenario analyses, and they had their views about which they thought was the most reasonable. And they sort of went through all the data and decided that, yes, that's fine. About £20,000 is the right sort of result. That's fine. So the other bits of the submission that they made, so they also submitted a cost effectiveness claim. So this all of these dots here come from the sensitivity analysis that was done around sort of input parameters. So when you do an analysis, I mentioned this briefly earlier, if you're doing within trial analysis, you can do bootstrapping, and that gives you something that looks like this diagram. It gives you a bunch of dots around your central point. This is a decision model, so they've done their joint sensitivity analysis, and it's given them a bunch of dots around their central point, and that's how we do the cost effectiveness analysis. So we don't use p-values because we don't have just outcomes, we have outcomes and costs. So because it's a joint analysis, we're not using p-values, there's no hypothesis testing. Instead, we use the cost effectiveness plane, and we use the joint analyses that give us this cloud of dots on the cost effectiveness plane. Sorry, I'm going to come back to that after I've run through this bit. Thank you. So the way, so we also then translate these dots. So the dots are, you know, are lovely, but they're not that easy to interpret. So what we do is we translate the dots on the cost effectiveness plane to the cost effectiveness acceptability curve. And we do that using the thresholds. So we draw a number of lines. We don't literally draw a number of lines, but the idea is that there are a number of different thresholds, and you can plot your line and you can look at what proportion of the dots from your sensitivity analysis that you've done jiggling the input parameters, what proportion of the dots are underneath the line. So the threshold line that we have here is £20,000 per QALY. Proportion of the dots underneath the line is about 40%. So that's this blue curve here on the cost effectiveness acceptability curve. If we have a different threshold, so a steeper threshold, where we would accept something for a higher ISA. So our threshold now is £40,000 per QALY. The proportion of the green triangles under this line is about 80%. So that's another point plotting this cost effectiveness acceptability curve. Then if we go all the way up to the top here, so £80,000 per QALY, so the gradient's gone up even more. We're nearly at 100%. So this is drawing the cost effectiveness curve, acceptability curve, from the distribution of dots on the cost effectiveness plane. And this is what we present instead of p-values and so forth. We show the probability of the new treatment being acceptably cost effective compared to the old one. And we can see yeah, so this is from the original submission. So the numbers in the final one that the ERG accepted are slightly different, but this is just to illustrate how you draw the cost effectiveness acceptability curve, which is really the sort of final result that we show the decision maker. So another case study, this is prostate cancer. So this is looking at abiraterone, which is a prostate cancer drug given in high-risk prostate cancer patients. So there was a within-trial analysis using the STAMPEDE data, which is a multi-arm, multi-stage study run by the MRCCTU at UCL. So it was a multi-arm, multi-stage. I think they got to about, I don't know, 12 arms in the end. The abiraterone one was arm G compared to the control arm A. So this was 10 years ago that these patients were recruited. We recruited nearly 2,000 patients for this comparison. So the comparison looked at the abiraterone arm patients, and it compared them to the control arm. Sorry, ADT is the control arm, which is androgen deprivation therapy. It's a hormone therapy. And these patients in the control arm were recruited in the same window as the abiraterone arm patients in this multi-arm, multi-stage trial. So we captured pathway costs and quality of life. We calculated QALYs. We did a bit of survival modelling to estimate progression and death, because we didn't get all of this from the trial, because the follow-up that we had at this point was a median of 5 years. And we wanted lifetime. So we extended the analysis to a lifetime decision model, and we filled in a few gaps here and there. There was some missing data around drug dosages. So we filled in some gaps where we knew what they'd actually been given and they just hadn't written the number in, and around monitoring and other costs. So this is always an issue with trials. People who are in trials get a lot of appointments for their trial, and so they don't always get the sort of standard monitoring that they would have if it was just rolled out in the real world. So we made some assumptions there around what would they get for monitoring visits if they weren't in the trial. extrapolated to the lifetime horizon, and we discounted. So yeah, because this was lifetime, we discounted using the standard nice rates. And then these are the results. So this is a table looking at the mean per patient costs over the lifetime and the mean per patient QALYs over the lifetime. It's quite expensive, but you know, that's what it costs. So I've used different acronyms, sorry. Standard of care here is the hormone therapy. We've got the difference in costs and the difference in QALYs and the incremental cost effectiveness ratio. So there's two halves to this table because there were two quite separate subgroups in the trial. So there's the non-metastatic patient subgroup. So these were less ill. And then the metastatic disease. So metastatic disease is when the cancer has spread around the body, and it's worse prognosis and a bit harder to treat and worse quality of life. So there are two quite different subgroups in the trial. The non-metastatic, who had a really high incremental cost effectiveness ratio, and the metastatic, who were a bit less well at baseline, but had a lower ISA for using this new drug. So here again are the sort of overall results. So cost effectiveness plane, cost effectiveness acceptability curve. So it was not cost effective in either subgroup. Definitely not. Sitting well over the threshold. And this is a £30,000 per QALY threshold. You can see the red line is the abiraterone arm, and the red line is showing that it's very low probability of being cost effective until you get up to quite a high threshold. So it's not looking great. But one thing we did know was that we had definitely used the wrong price. So we were using the British National Formulary price because that was the only price we had, because it's confidential. The price of abiraterone to the NHS is confidential. So we didn't know what it was, so we couldn't put it in. So we did a threshold analysis. We put in different lower costs to work out how cheap would abiraterone have to be in order to be cost effective. And it turns out it could even be cost saving. In the non-metastatic subgroup, you can have a negative difference in costs. So the abiraterone arm would dominate. It would be cheaper and better if the cost is down to 10%. Happily, abiraterone is now generic, and the cost is around there. So fortunately, this is happening, which is nice. So in both the patient subgroups, obviously, as the drug price goes down, it gets more cost effective, because a big part of the cost of the whole thing is the drug costs. Yes. Have you got questions? Okay, good. So this was just a threshold analysis, sticking in different numbers to seeing what the result was. This is a graph showing exactly the same thing, and I've just drawn straight lines here to show that when you get to £11 a day, so this was just under £10 a day for the abiraterone costs in the non-metastatic subgroup, being cost saving. So still giving you more QALYs, but giving you less costs. And it hit the zero mark at £11 a day. So any price of abiraterone of £11 a day or less should be cost saving to the NHS in terms of better health outcomes and lower cost. So the generic pricing is around this, which is good. And Scotland has approved abiraterone in this group, which is good. We hope NICE will follow soon. But yeah, so that was a big policy change. So we are very nearly at the end. We've talked already about limitations of EQ5D and QALYs. There are more limitations of economic evaluation. So it's only one part of the decision-making process. The evaluation is only as good as the input data, rubbish in, rubbish out. So trial planning is important. and generally making sure you've got the best data that you can. We've got the same issues with trial population that I think I mentioned earlier. Precision of results is tricky, so dealing with missing data is quite difficult, especially because it's a joint analysis. But there's a lot of work going on at the moment to try and standardise this. And if resources are saved, then that's great, but there's nothing in the analysis that we can say about how it should be used. Okay, and conclusions. This is the last slide. So healthcare resources are always finite. We talked at the very, very beginning about budgets and making decisions between spending on option A or option B. There's always a decision. There's always a decision. There's always an opportunity cost. Every decision that is made in terms of how healthcare services are organised and how much they cost and what they are has an opportunity cost where you could have done it a different way. That's because these resources are finite. Time and money is finite, even in healthcare systems that have different organisations to themselves. They still have finite resources. So there's always some decision, some form of rationing. What we want to do is provide transparent evidence for how to make these decisions around what should be spent on what. Cost per QALY is very useful at a national level. We also think about things at the local level in terms of, for example, implementation costs or budget impact. Yes, so there are limitations all over the place, but economic evaluation using EQ5D and QALYs is currently the least worst option. There are some references here, so it's a bit of further reading. I'm going to end on this shameless plug for 2 online MSc programs that's run by the Institute of Clinical Trials and Methodology at UCL. And there's also a one-day course that I run at UCL, which next one's in July. Do come along. There's a QR code there. Right, any other questions? So I've got one more question in the chat. Does NICE also consider future value? Yes, so this is another tricky one. What if you heal somebody from one disease and then they get older and they get dementia and they cost lots of money then? This is, in very, very simplistic terms, that's the kind of impact that in the UK we don't include. Other countries do sometimes include these sort of longer term health impacts and so forth. But in the UK, we don't currently do that. Some places do. There's an argument that you should and an argument that you shouldn't. Yeah, it's tricky. Good. Thank you, everybody. Does anybody have any more questions? Please do unmute and shout or put things in the chat.
Hi, Caroline.
Yes. Hello.
Is there any have you ever worked on a trial with more than 2 arms before?
Yes, I've got one going right now. It's looking at sinus surgery. So we have a surgery arm and a long-term antibiotic arm and a placebo medication arm.
Okay, and how do you find doing the ISA for something like that?
Yes, so you can either do 3 different pairwise comparisons or you can do a multi-arm analysis. So there's a paper, I've also done a multi-arm analysis on breast cancer, which might even be in the, no, it's not on the slides. So you can do multi-arm analysis where instead of calculating the ISA, you calculate the net monetary benefit. And what that means is you calculate, so you calculate the costs for each arm and you calculate the QALYs for each arm, and you think about a willingness to pay, so £20,000 per threshold per QALY, and you put that into the net monetary benefit equation. I can send you a paper about it. Yeah, but yeah, there's a very straightforward way to do multi-arm comparisons. Yes. Are there methods being explored to make QALYs less subjective or reduce reliance on quality? Yes, all the time. All the time. Office for Health Economics has seminars on this sort of thing. There's lots of research going on around how to improve them and work out what else is wrong with them. There's lots of things wrong with them. Multi-arm comparisons, can we compare each? Yeah, I mean, you can do whatever comparison you like, so long as you specify it in your health economics analysis plan beforehand, and say what you plan to do, then yeah, you can. That is ultimately what happens. So if you're comparing all of the arms against each other, then you end up, let me see if I can show you a bit. You end up with a cost effectiveness acceptability curve that has all the different arms on it. Let me just find a picture. So for example, where's he gone? Oh. Why am I not sharing? Hang on. No, that's not it. Sorry, sharing the wrong thing. No, it's this one. There we go. Right. So this is a paper I did a few years ago, which was a 3-armed analysis. And what we ended up with, so yes, so 3 arms, no trastuzumab, this was breast cancer, no trastuzumab, 9 weeks of trastuzumab, Herceptin, or 12 months of Herceptin. Very simple decision model. And the results that we came up with were this. So this is the cost effectiveness acceptability curves. It's got 3 curves on it. So it's got the 12-month one, which was never acceptably cost effective because it was really expensive and didn't give any extra benefit. We had the 9-week one, which was pretty much the winner. So this one went up to be expected up here. And we had the 0, which started off the best if you didn't want to spend any money, and then went down. So the cost effectiveness acceptability frontier is the top bit of this all the way along. So this is all 3 arms together on a curve. Does that make sense? Oh yes, there's a feedback form. Please do complete the feedback form. Katie, can you send that round? What happened with the CF curve? Lee, can you send me an email and I will send you the papers? There's a or unmute and yes, okay, good, great. Thank you. That'd probably be easier.